Welcome to the liver lymphovascular terrain presentation. This is part 5 in the series. My name is Ivan Dubin. I'm an osteopathic practitioner in Vancouver, Canada. As always, just want to remind everyone I'm not a physician. If you need medical advice, please consult a physician. Some of the topics we're going to cover today: the historical precedents on the importance of the liver in lymphokinesis and homeostasis, some liver facts, talk a bit about Philip Druelle's central chain and how it relates to the liver and the area below the diaphragm. We'll talk about the liver phases of detoxification, talk about some liver anatomy, some liver lymphostasis, or stagnation in other words. Get into the liver lymphatics, talk about the gallbladder and biliary tree lymphatics, talk a bit about liver pathology, in particular related to manual therapists, portal hypertension, frozen shoulder. And then we'll talk a little bit about the diaphragm as well. Before we move into the liver, let's just do a quick review defining lymphovascular terrain. Here's a great image that shows you the interrelationships between the arteries, the veins, the lymphatic vessels, the tissue cells, and the interstitial fluid. The only thing that's not visible in this image is the consideration for mucosal and submucosal layers that contain the epithelial and in some cases endothelial cells, and the microbiome would be overlaid on top of this as well. Another important consideration of lymphovascular terrain is the lymph node itself. What's key here to appreciate is that each individual lymph node has blood vessels coming in and out of supporting the lymph node. So you've got lymph coming in from other lymph nodes, surrounding lymph nodes. That whole area is being supported by detoxification process of blood coming out and toxicity being pulled out. As well, that lymph is moved on to be processed in another lymph node. The next example of lymphovascular terrain deals with the architecture of the small intestine, looking at the intestinal villi. Again, here you can appreciate the arteries, the veins, lymphatic vessels. Each individual villi has support from artery, a vein, and lymphatic vessels. And then further down, we start to see the submucosal layers and mucosal layers, as well as the nerves interacting in this whole terrain. So the nervous system is another aspect of the lymphovascular terrain. And in this image, also, you would not be able to appreciate the microbiome. Before moving on, we just want to appreciate the fact that the way I'm describing the lymphovascular terrain or any of the aspects of the lymphatic system, we're superimposing it over the vascular tree. In essence, with the vascular tree, you've got the arterial system, the heart arterial system, along with the structured water phenomena, moving blood from the center to the periphery. Then the blood is being sucked back through the negative pressure above the diaphragm and relative local tissue pressures being brought back towards the center to be deposited back into the heart. In between that, you have the aspects of the lymphatic system, and of course, as I've talked about in previous presentations, the lymphatic systems wrap around arteries and veins starting at the periphery, and they have to move back towards the center it gains resistance, tissue resistance. And so when we have an excess of tissue resistance, then we start to have problems with lymphostasis. Keeping in mind that traditionally the venous angles is the final destination of the lymphatic system. However, I also will discuss why I think that a great deal of the lymph is being processed individually in the lymph nodes. As I've noted, they have a vascular supply on their own. This is a basic rendition of the lymphatic systems I just explained. It just doesn't give you the direction of flow. It's difficult to see the depth of the deeper lymphatic system from this type of imagery, which is the whole point of providing some of these the images in these presentations. As I've said, we've gone through cranial and cervical and mediastinal, so I'm not going to get into great detail. Of course, you had in the cranium you had the lymphatic system. This represents aspects, again, the green being lymphatic system, closely connected to the venous system, interacting. And again, more detail in that presentation if you're looking for it. And there were also superficial lymphatics that are moving from the face to the cervical spine, including the deeper cervical lymph nodes. Here's an example of some of the lymph nodes and vessels as they're traveling down through the posterior cervical spine. Another example of some of the lymph nodes that are supporting the thyroid gland. As you can see, when you start to look at the arteries and the veins here, the jugular and the carotid, you can really see how the lymph nodes are organized and essentially sort of wrap around those structures, moving down towards the mediastinum. At the mediastinum, we see the complexity of the deep nodal chains. We can see how the diaphragm and the liver are supported by these chains. So, here, you can see my pointer here, we're dealing with diaphragm. The liver's not in this image, but you can see how these lymph nodes are connecting deep into the system, supporting heart and pericardium, which I say we already covered. Here, this image gives you, on the right, we can see the vascular component of blood supply to the heart. And the image on the left is giving you an indication of the lymphatics. Now, the lymphatics are actually in red on this one, and the green is the arteries. But it does show you that the heart itself has lymphatic support as well, and that's all considered part of the lymphovascular terrain. Intrapulmonary lymph vessels, also part of the lymphovascular terrain. We can see how the lymphatic vessels, these aren't nodes, but these vessels are followed down into the architecture of the lungs. And one of the only places where there is no lymphatic support is at the level of the alveoli. Here again, we're looking at mediastinum and complex imagery, but at the bottom here we do have the diaphragm, and we can see how these nodes, these are deep nodes that are connecting in through the mediastinum, supporting all the structures, connecting from deep to superficial. You can also see how coming down from the cervical spine, these nodes are all connecting. This image doesn't contain the liver, as I said, but it does represent the various interconnections going to and from the liver, which we'll get into more detail as we start to discuss the liver. Some early osteopathic viewpoints. According to Millard, the liver is the chief organ in systemic pollution. That is, in the majority of cases, the liver is involved primarily and the other organs are affected secondarily. If the lymph drainage of the liver is blocked, it's only a short time before some other organs will take on a diseased condition. That quote's 100 years old. It's just as relevant today as it was back then. My clinical experience with cases involving regional or global edema has highlighted the importance of organizing the liver itself in relation to other organs and its surrounding structures. Another quote, there is no organ that blocks itself quicker than the liver. Systemic response to inflammation occurs in the liver and the brain. And coming from Shikli, the lymphatic drainage system of the liver, including the retrograde drainage following along the portal vein, is one of the earliest visceral lymphatic circulatory systems to be classified by the anatomists. Historical presidents had a grasp on the importance of the liver, as surgeon Giovanni Riva concluded that the circulatory system was based on the hepatocentric model provided by Galenic physiology, which suggested the blood was created in the liver. I suspect that the early anatomists utilized fresh cadavers in their dissections and investigations. Given the amount of blood that's held in the sponge-like characteristics of the liver, it's easy to see why they considered it the center of the circulatory system. The heart would contain very little blood relative to the liver in a recently deceased person, mostly because the heart is comprised of two muscles that suck and pump blood through it, so the blood doesn't linger in the ventricles. Some specific osteopathic lymphatic techniques using a few minutes of local manual pumping to reduce swelling in and around the organ, such as the pressure-sensitive liver, were described in the profession's literature as early as 1891. That comes from Anthony Chila. If we're looking at the early anatomist drawings of the circulatory system, we can clearly see that they didn't include the heart, but they did include the liver, which is fascinating. When we begin to look at how the blood is being distributed through the body under basal conditions, we can begin to see that roughly about 65% of the total blood in the body is comprised of kidneys, liver, and the portal vein, with the brain being about 14%. So between those three, it's quite a lot of blood that's being held in those areas. Some basic liver facts. The liver can move in a superior-inferior direction, approximately 3 to 8 centimeters during maximum inhalation and 1 to 4 centimeters during normal inhalation. This information comes to us from the American Osteopathic Association via the text Foundations for Osteopathic Medicine. Liver can also move in an anterior-posterior and medial-lateral direction. In terms of palpation, it's important to assess the firmness or consistency of the liver in order to consider cases of density due to fibrosis or congestion. The idea is to, quote, catch the liver while compressing both hands together to determine if there's an area of dysfunction. Prior to treating the area of dysfunction in the liver, it's imperative that any restriction at the celiac trunk be resolved. Easier said than done, but that is something that I'll be covering as we progress into the celiac area in the next presentation. All of this work on the liver endeavors to improve the arterial pulse, remove neurological congestion, and remove any resistance to lymphatic flow at the thoracic duct. Now, this lymphatic flow at the thoracic duct is the entrance to the thoracic duct before it moves up through the mediastinum. And as I pointed out, and I'll show you a little later in the images, that entrance is essentially under the left lobe of the liver next to the artery. or the abdominal aorta. There is no organ that blocks itself quicker than the liver. That's coming from Millard. The liver is nearly totally covered with a dense irregular tissue and a visceral peritoneal layer. It is divided into two lobes, a smaller left lobe and a larger right lobe, which are separated by the falciform ligament. The falciform ligament also acts as a suspension for the liver within the abdominal cavity. The ligamentum teres is a cord attached to the falciform ligament, and it is a remnant of the umbilical cord during fetal development. Blood exiting the intestines contains various bacteria, bacterial endotoxins, and antigen antibody complexes. At roughly 2 quarts every minute, the liver filters 99% of bacteria and toxins when functioning optimally. 2 quarts is roughly 1.9 liters. Also important distinction, located inside the various ligaments of the liver, there are lymphatic vessels that help move lymph away from the liver. So in essence, inside these ligaments here, you have lymphatic vessels that are moving in different directions, helping support lymphatic flow in the protected casing of the ligaments themselves. The liver is a 6-sided structure comprised of functional units called lobules. There are also hepatocytes that are specialized cells arranged in irregular plates surrounding the central vein. I'll have some images of these coming up later. There are sinusoids that penetrate the central vein into the surrounding lobules and absorb blood from the digestive system. These are all things occurring inside the liver. The sinusoids are lined with fixed phagocytes called Kupffer cells, and these are endothelial tissue. They provide an immune response against pathogens, cellular debris, and toxins prior to the blood leaving the hepatic venous system as part of the filtration system. Endothelial cells line the arteries and lymphatic vessels. They act as an immune barrier, delivering oxygen and also helping deliver nutrients. They also assist in vascular tone and regulation of blood pressure. Endothelial tissues can be damaged by smoking, metabolic syndrome, hypertension, and physical activity. Endothelial cells assist in managing the migration of inflammatory cells and adhesions, such as plaque. The liver, similar to the spleen, is also a pressure-sensitive organ abutting the diaphragm. Looking at the imagery inside the liver, here we have the central vein. These are the Kupffer cells, spaces of Disse. You have the portal vein over here, and the bile ducts. So we're starting to see, if you notice, the sponge-like quality of the liver itself. Arrangement of the hepatic venous territories. So the 6 sections of the liver are a little more visualized here. You can see them divided as the venous system is supporting each one of those sections. Gives an indication of the various segments of the liver, including the venous system. The visual of the segments of the liver can explain variations in size, shape, and densities that differ from person to person. Having several segments allows for more adaptability of the liver as an organ. The adult liver extends into the left hypochondrium and epigastrium towards the left lateral line. The liver will reach its full size at 18 years of age, will begin to decrease in liver weight during midlife. The liver contains phagocytic macrophages, which participate in the removal of particulates from the bloodstream via the components of the mononuclear phagocyte system. If the liver helps to sustain body heat, it's easy to see how a congested liver could lead to excessive heat. This can present as hormonal night sweats or skin conditions such as eczema, psoriasis, etc. The heat has to be dealt with in some way, and the skin is the largest organ of detoxification. The role of the liver includes multiple biochemical functions such as maintaining body heat versus exothermic thermal energy production during rest. Other metabolic activities include breaking down and modifying amino acids, storage of certain vitamins, storage of iron and additional micronutrients, regulation of lipids and blood glucose, and removal of toxins from the blood. All functions contribute to managing the immune response, nutrition, and overall homeostasis. And we also have bile contained within each lobule inside of the bile canals, after it is created by the hepatocytes to be transported to the bile ducts. The bile ducts accompany each lobule and join alongside the branches of the hepatic portal artery and vein to form the portal triad, which we'll talk about a bit later. And we're looking at about 50% of the total lymph as a fluid production occurs in the liver itself. Note the sponge-like composition and histological architecture of the liver tissues. It's like a sponge. It's important to retain as much surface area as possible to have optimal participation in homeostasis. So like any sponge, if it loses its shape or its characteristics, it ceases to act efficiently or effectively as a sponge, which is likely why it has a capacity to expand or contract, and why, as Millard discussed, it can so easily go into lesion. The bile ducts organize into the left and right hepatic ducts, and along with the cystic duct, the gallbladder, form the common bile duct. The liver is associated with the greater part of the diaphragm, and it reaches below the costal margin anteriorly. The left lobe is approximately a third of the total size of the liver, and it covers much of the anterior surface of the stomach. Just a bit about liver embryology. The significance of the liver as it descends below the diaphragm with the other viscera contributes to the developmental movement of the entire embryo. This includes the phrenic nerve innervation of the diaphragm from the C4 spinal cord segment. The embryonic liver initiates the descent of viscera as it grows. There is intense vascularization involved in the development of the brain, leading to the expansion of the heart as it becomes the central mass of the vascular system at this stage. The evolution of the brain and heart prior to liver development gives us insight into a sequential approach to liberating the vascular tree. Therefore, optimizing blood flow to the brain and heart prior to addressing the limiting concerns of a dysfunctional liver may contain some merit. So, in terms of a treatment protocol, you can see how the body prioritized development of the brain and heart first prior to the development of the liver. The preceding growth of the brain and heart is an important prerequisite for optimal liver growth. In the fetus, the liver is the main center of blood production, and it evolves from an endodermal evagination of the foregut and from the septum transversum mesenchyme. The liver is one of the most precocious embryonic organs. In the developmental process, there's an intimate connection between the heart and the liver. The liver will fill the abdominal cavity, and the left lobe will be almost as large as the right lobe at 3 months gestation. Increased blood requirements to the heart and brain initiate more growth in the liver due to its proximity. The liver also begins to receive venous blood as it begins to act as a filter for blood heading to the brain and heart, and this is when it develops into the central mass of the intestinal tract. As the liver and heart continue to enlarge, there's a formation of a compressed plate of tissue caused by the expansion growth of both organs. This compressed tissue eventually evolves into the central tendon of the diaphragm. The expansion of the liver contributes to the developmental doming to flattening of the diaphragm. The left lobe will become smaller than the right through a process of degeneration as the spleen and bone marrow take over the homeostasis role for the liver. The liver will amount to 4% of the body weight in the neonate and approximately 3.5% in adults. Prior to birth, the liver ceases to be the center of homeostasis, but at birth it still does not have full capacity for enzymatic and synthetic function. Likely why it's so important to inherit the mother's immune system through a natural birth and breastfeeding. Moving on from embryology, if we just briefly discuss Druelle's central chain, again, the components of his chain are the vertex, the third ventricle, the SBS, veno-basilar symphysis, the esophagus, trachea, pericardium, heading to the central tendon of the thoracic diaphragm, to the head of the pancreas, the root of the mesentery, the uterus or isthmus, ending in the central tendon of the perineum, moving its way from the head to the bottom of the pelvis. According to Druelle, the following structures connect off the central tendon of the diaphragm as part of the central chain. And since we're focusing on the liver today, we're going to only kind of just take note of these aspects of the central chain. We have the coronary and triangular ligaments of the liver. And this is descending right of midline. We have the liver falx. We have the head of the pancreas. As we descend through the midline of the central chain, we have the lesser omentum, the hepatogastric ligament, and the head of the pancreas. Here we can see how the central tendon is poised to act as an anchor as the central chain bifurcates to the left, to the center, and to the right. And so we can appreciate the tendinous aspect of the central tendon. Looking at the diaphragm from below, again, here we have the mass of the central tendon. We can appreciate the surface area that the central tendon affects, moving away from the connections of the central chain. Let's go back to the liver itself and discuss its role in detoxification. Getting into liver detoxification, phase 1 detoxification occurs mostly in the right lobe of the liver as it receives blood from the superior mesenteric vein portion of the portal vein complex. We can view this phase as breaking down compounds and then sending the raw materials to the left lobe for the phase 2 stage. That which cannot be absorbed in the small intestine will be sent to the right lobe of the liver for metabolic conversions by many types of enzymes. The toxic metabolites will be shunted to the left lobe for phase 2 conjugation in order to make them safer for the body to use. Phase 1 detoxification will be impacted by an underactive phase 2 capabilities. Underactive phase 2 capabilities can be viewed as the left lobe being under the influence of some type of osteopathic lesion. Densities, compactions, compression, adhesions, or expansion, such as fatty liver, and overall tissue degeneration due to inflammation will have a strong impact on the left lobe of the liver. As I discussed earlier, the left lobe of the liver is positioned to influence the thoracic duct as it sits next to the abdominal aorta. So it's a critical piece. And when the left lobe is not available for ideal detoxification, that's when you'll start to see issues with the skin coming up, because the body requires assistance in detoxification, and your skin being the largest organ of detoxification, you start seeing rosacea or eczema or psoriasis. There's typically involvement of the liver, in particular left lobe, and that would include small intestine as well, but we won't cover too much of that in this demonstration. In terms of liver detoxification pathways, phase 2 in the left lobe. Phase 2 detoxification pathways are described as the conjugation or building pathways. The process relies on the conversion of fat-soluble toxic compounds and transforming them into water-soluble compounds prior to leaving the liver via the intrinsic venous, lymphatic, and biliary systems. Conjugation combines a metabolite or toxin with a substance that adds a polar hydrophilic molecule in order to convert lipophilic substances to water-soluble forms for excretion and elimination. There are 7 different major biochemical reactions which occur in phase 2. These are glutathione conjugation, amino acid conjugation, methylation, sulfation, acetylation, glucuronidation, and sulfooxidation. Each of these reactions require specific types of intermediates in addition to specific nutrients required for successful completion. Those are essentially the pathways, detox pathways. And clearly, if the left lobe of the liver has increased density, lack of optimal blood flow, or limited PRM expression, this will interrupt the detoxification process, leading to lymphostasis and increase in allostatic load and inflammation, and likely the biliary participation will be impacted by left lobe dysfunction, which will have present as digestive symptoms. Bile excretion can be viewed as a secondary detoxification process whereby toxins are modified and synthesized for removal back into the digestive system to be absorbed by fiber and then excreted. Approximately 1 quart of bile is produced in the liver every day, and limited bile excretion will elevate liver toxicity. This can also occur via biliary duct obstruction or impairment of flow within the liver. Here you can, again, this drawing, note how the biliary ducts and associated structures weave their way into the tissues of the liver, creating its own type of matrix. Note the position of the gallbladder itself is vulnerable to any increase of tissue pressure within the liver, since it is surrounded by the liver. Any alterations in the tone of the liver itself, left lobe or right lobe, any contractions or expansions will inevitably affect the gallbladder. When the shape of the liver is altered, the ability of the liver to fully participate in detoxification and various metabolic functions, the process of homeostasis will be hindered. The result of a hindered liver can be systemic, regional, or local fluid retention, meaning that fluids of various metabolic distinction are left over and stored in the various tissues as edema. This happens as the body cannot process the amount of fluidic balance required in the metabolic detoxification process. The body will always store excess metabolic fluids in tissues. It depends on the individual and the type of physiological adaptability and their body type, but you can look for this in various areas, as puffiness in the ankles, inner thighs, groin, inguinal area, the abdomen, the chest, the arms or armpits, the neck and the face. When you're assessing it, you just have to tap the skin and you'll see that it'll sort of respond like if you were tapping on top of a pond. You can kind of sense the water that the body's holding. Weight gain is often fluidic in nature and could be viewed as local, regional, or global swelling due to the inefficiency of the body, in this case the liver, to manage bulk load. From a structural functional point of view, I'm going to keep in mind the association of the liver with the diaphragm has implications on the limitation of diaphragmatic movement, which will alter global pressure gradients, well, first regional and then global. That will result in fluid retention as well. So we want to reintroduce the optimal shape, position, size, and tone back to the liver. This can have profound implications on the pressure gradients. Also, the attachments connecting the liver to neighboring structures via the various ligaments and sheaths, they require persistence to liberate the liver due to the complex interconnections with surrounding structures. Looking at some liver anatomy, the normal tone of the hepatic artery and its branches are responsible for augmenting the lymphatic drainage of the liver. The hepatic artery produces the branches for the cystic artery, gastroduodenal artery, and the right gastric artery. There are also direct branches to the bile ducts from the hepatic and supraduodenal artery. Once leaving the celiac axis, the hepatic artery passes laterally and anteriorly beneath the epiploic foramen towards the cephalic aspect of the beginning portion of the duodenum. The hepatic artery can be divided into the hepatic artery proper and the common hepatic artery, which travels from the celiac trunk to the origin of the gastroduodenal artery. The shape and function of the liver relies directly on the quality of blood flow available to it, but the liver must also be available to receive optimal blood flow. Manual therapy can often be a balance of direct work on the liver prior to addressing blood flow, or vice versa, where you treat the blood flow before addressing the liver. Consider that the path of the hepatic artery is subject to tissue tension or compression from surrounding organs and structures. Like a branch coming off a tree trunk, it winds its way to the liver. Pressure or bloating in the epigastric area is an indicator of increased tissue pressure and likely a contributor to digestive dysfunction. My observation is that that prior to directing focus on the liver blood supply, it is imperative to restore at least the position of the liver to a more receptive place. I call it bringing the liver back home. This requires considerations for the attachments of the liver to the diaphragm and its interactions with the stomach as well. Ultimately, any organ or structure above or near the liver, such as the diaphragm, has an influence on local tissue tensegrity, pressure gradients, and liver position. We get an idea here of the branches of the hepatic artery. Here's a combination of the arterial and venous supply of the liver, both forming what look like two trees that come into the liver to support all the different segments of the liver. So if the shape of the liver liver is any one of the lobes is altered in any sense, that will affect blood coming in and blood coming out. Here we have the venous drainage that occurs within the liver as it makes its way from the liver to the vena cava. The hepatic venous system drains blood from the liver parenchyma, and the portal vein conveys venous blood from most of the gastrointestinal tract and associated organs. The portal vein will divide into left and right branches and further divide into the various segments of the liver. Blood coming from the digestive system to the liver via the portal system has two distinctions that are worth consideration. The blood flow that is received in the left lobe is primarily from the gastric, splenic, and inferior mesenteric vein, while the right lobe of the liver receives blood supply primarily from the superior mesenteric vein. There is also a zone of amalgamation in between the two lobes. Some treatment considerations focusing on the posterior aspect of the liver are important in ensuring proper venous drainage of the parenchyma of the liver itself. The portal vein is a vein that acts like an artery, and it is bringing in blood from the gastrointestinal region. Keeping in mind that blood from the portal vein is of a different quality than arterial blood. This allows us to consider that the liver works like a metabolic sponge, and that it absorbs blood from the portal vein and receives blood from the hepatic artery. Any deviation in the shape of the liver caused by underperforming liver segments can affect the capacity of the liver to behave like a sponge. This means less surface area for its physiological participation in the dynamics of health. This diagram will help us note the distinction between the inferior and superior mesenteric venous systems combining to form the portal vein. The role of the left and right lobes of the liver are supporting different aspects of the portocaval system. It's easy to consider that if the left lobe of the liver is not available to receive venous blood from the inferior mesenteric vein, you may have a backup of blood or venous stasis in the descending or sigmoid colon region. Can also present as pressure-related lesions of the sigmoid colon, such as hemorrhoids, or with puffiness in the pelvic groin area. And you might also notice recurrent infections, bladder infections, things of that nature that are chronic. There might be some local inflammation in the form of edema in the area. When we look at this diagram here, we can see the portal vein entering the liver, but there are two aspects to it. So here, coming down, you have the inferior mesenteric vein, and then here you have the superior mesenteric vein, both of them forming to come in to the different lobes, and obviously the left lobe being here and the right lobe being here. Looking into hepatic innervation, according to Ward, there is still little known about the implications of autonomic nerve stimulation on liver function. Sympathetic facilitation encourages increased glucose output in the liver. There's an abundance of sensory axons located in the vagus and thoracic splanchnic nerves that arrive at the liver. And approximately 50 of the splanchnic axons and 90 of the vagal axons arriving to the liver are visceral afferent fibers. These two distinct afferent systems serve different purposes. Currently, all available research suggests that all pain sensory functions associated with the liver travel along the splanchnic nerve and not the vagus nerve. Note the interaction of the nerves and lymphatics in the epigastric region in support of the liver. So here you have the liver and your stomach, and in the center your plexus, nerve plexus, but then you also have the biliary system, and locally you will have lymph nodes that are surrounding it, plus you have the celiac axis here, the hepatic arteries. So there's a great deal going on in the epigastric area, hence the importance of addressing it properly to be able to get into this area without putting the liver and diaphragm in an ideal position makes it very difficult because there's just too much pressure in this area. The vagal afferent axons that travel along the pathway of the nerve will respond to various stimuli such as portal venous blood osmotic pressure, plasma glucose concentration, and changes in temperature. In contrast, the visceral afferent fibers of the splanchnic nerves are termed as high threshold chemoreceptors and mechanoreceptors that respond to stretch and bradykinin concentration. They're situated in the walls of the biliary system as well. Both divisions of the autonomic nervous system provide innervation for the vasculature and parenchyma, the pancreas, liver, and all related ducts. There are also significant amounts of visceral afferent fibers that travel with the vagus and thoracic splanchnic nerves, and preganglionic sympathetic innervation for the liver and pancreas begin in the thoracic segments of T6 to T11. The chemoreceptors themselves are special nerve cells that detect changes in the chemical composition of the blood and send information to the brain to regulate cardiovascular and respiratory function. There are two main types, which are peripheral and central chemoreceptors. They are sensitive to arterial carbon dioxide as well as decrease in arterial pH. They also, because they're all over the body, they are going to respond to toxicity by triggering pain receptors, which can further trigger muscle contractions and nerve irritation. So what's often perceived as a nerve issue, it can often be linked back to a toxicity issue, especially in the case of frozen shoulder, which I'll touch upon coming slides. Getting into liver lymphostasis, scientific publications have acknowledged that the ascites developing from hepatic cirrhosis originate from lymphostasis. A reminder that the role of the lymphatic system has also been linked to cases of cardiac cirrhosis, which I talked about in my previous presentation on the mediastinum. Cardiac cirrhosis is a condition that can be related to right ventricular heart failure, along with edema, ischemia, and limited venous drainage. The combination of venous hypertension with elevated lymphostatic preloads and afterloads will lead to liver damage. That's Foldy talking about what it means when you are holding too much bulk metabolic fluid, including lymphatic fluid. You get congestion, you get tissue degeneration, which leads to the possible cirrhosis. During experimental ligation of the lymph vessels located in the hilus of the liver by Foldy, he initiated lymphostatic hepatopathy, resulting in interstitial edema with massive dilation of pre-lymphatic channels called Dysfunction spaces. Hepatocytes were found to be damaged due to intercellular edema. Following the oxidative phosphorylation that occurs with the disruption, there was an accumulation of fat inside and outside of the hepatocytes. When the condition persists, there will be a reduced transport capacity of the hepatic lymph vessels, leading to extensive damage to the liver cells. Eventually, severe lymphostatic hemangiopathy will ensure, and there will be a narrowing of the lumen of the blood vessels. These are all steps that are involved in the establishment of hepatic steatosis or fatty liver. Looking at the liver as a metabolic sponge, the sponge-like capacity of the liver explains its capacity to alter its shape. If structure governs function, then we can also conclude that decreasing health and vitality accompanies the, quote, aging process, which I prefer to view as a loss of adaptation versus a notion that it is a genetic predisposition to the liver losing its shape and mass. Homeostasis activity includes adaptations of physiology described as allostasis. We'll see changes in health status the longer we live. How we age will depend on factors that contribute to sustaining or slowing down the loss of viability and in avoiding damage as a result of the increase in allostatic load. These include internal and external environmental stressors, and lymphostasis and edema is an example of allostatic load, as I already covered in my second presentation on dynamics of health. In essence, the shape or structure of the liver will correlate with function, meaning that a dysfunctional architecture or shape of the sponge will limit the ability of the liver to support its tasks. Again, here we have an example of the sponge-like quality of the liver tissues. Here we can see the interaction of the hepatocytes with the biliary canals. You can see how an accumulation of fat around the hepatocytes would also negatively impact bile flow. This is one aspect of hepatic steatosis, and it creates a vicious cycle of congestion and inadequate detoxification and digestion. All these would be factors. Just touching on the movement of lymph within the liver, lymphokinesis, and some associated pathology that comes up when it's limited. Chronic liver disease, a leading cause of 2 million deaths per year worldwide. The disease will be precipitated by cholesterol buildup in the liver, steatosis, and inflammation. Optimal liver lymphokinesis ideally removes proteins, immune infiltrates, and cholesterol. The lymphatic endothelial cells are critical in managing the potential contributing factors to liver disease. The sinusoids inside the liver are permeable and hold more protein within the hepatic lymph as compared to other organs. Lymph from the interstitium of the liver flows into the Dc space, lying in between the blood sinusoids and the hepatocytes of the liver. Then the fluid flows through the spaces of Moll near the intersection of the portal system and nearby hepatocytes. Of course, we know many chronic health conditions are interrelated with edema and inflammation, especially the hidden inflammation that I've talked about in previous recordings. And that's related to environmental factors, nutrition, lifestyle choices. So we want to try and prevent erosion of cellular terrain and have continued vitality and health status. Once leaving the spaces of Moll, almost 80% of the lymph then flows into the lymphatic capillaries along the portal system, and the lymph drains in the same direction as the bile away from the liver. So it's definitely moving against the venous blood that's coming from the portal system into the liver, and again against the hepatic artery. So the lymph has to move in the opposite direction. Backflow is ideally controlled by the lymphatic valves located inside the collecting vessels. The capillaries then drain lymph into lymphatic vessels, which are surrounded by lymphatic muscle cells. It is the lymphatic muscle cells that pump the lymph from the liver through the nearby celiac and portal lymph nodes into the cisterna chyli, and that's providing there's ideal pressure gradients to allow that to happen and no scars or anything to impede the flow of lymph to the cisterna chyli. There are also sublobular lymph vessels located along the inferior vena cava. So we can begin to see that the lymph is moving below the liver, caudally towards the cisterna chyli, then coming back up through the thoracic duct cranially. We also want to consider again that because the liver is acting like a hub, there's lymph that's leaving the liver via various ligaments and also other connections to lymph nodes in and around the diaphragm, deep and superficially, joining the thoracic duct further up in the mediastinum. It is thought that any deviations or dysfunctional lymph flow in any of the respective areas can end with liver disease. There is increased lymphatic vessel density in cases of idiopathic portal hypertension and primary biliary cirrhosis. Increased cirrhosis also leads to an increase in the volume of lymph drainage from the liver, which must be managed by regional lymphatic terrain. And that's when the body starts to store it as is being overwhelmed. The increased lymph drainage is another contributing factor, as improper removal of inflammatory mediators and cells is decreased due to the permeability of the lymph. This affects the community of beneficial cells in the lymph pertaining to the liver, and this has a negative effect on the endothelial cell environment, ending with leaky lymphatic vessels as well as adipogenesis of the liver itself. Delving into more of the liver lymphatics, the liver has the left and right lobe, as well as the deep and superficial lymphatic drainage pathways. The convex and superior surface of the liver drains through specific pathways following along the falciform ligament and the vena cava as it passes through the diaphragm towards the mediastinum. So this is lymph that's moving back, not towards feet, back towards the midline and up through the body. The deeper drainage of the liver moves along the concave surface in an inferior direction towards the hilus of the liver. These specific lymphatics then drain into a retrograde direction along the portal vein, opposite the direction of the blood flow leaving the small intestine and terminating in the liver. So again, we have a cross-flow as the liver is acting like a hub, sending lymph in all directions. The retrograde flow occurs until the lymph flows into the celiac nodes prior to entering the thoracic duct, and that is going to depend on the pressure gradients around the entrance of the thoracic duct. If there's too much pressure, as I talked about before, with for instance the lack of optimal position of the liver or too much pressure around the left lobe, that will have an impact on the thoracic duct, which will have an impact on the ability for the cisterna chyli to properly drain to the thoracic duct. The convex surface of the liver articulates with the diaphragm, and there are nodes that are shared for drainage between the two. The bottom surface of the liver, including the bile ducts, are serviced by lymph vessels that pass to the hepatic and pericardial nodes, and they are part of a chain that connect to the gastric lymph nodes. The region of gastric lymph nodes also receives lymph from the nodes at the esophageal opening of the diaphragm, and they are in communication with the nodes of the pancreas. There are also lymphatic tributaries that collect lymph from the bottom surface of the liver that follow along the hepatic artery, the portal vein, the bile ducts, and they all lead directly to the receptaculum chyli. So this is an example here how the lymph is flowing against the hepatic artery and portal vein. They're bringing blood into the liver, but the lymph is moving out of the liver next to these structures, in some cases wrapping around them like a vine around a branch. So you can imagine any dilation of the portal vein or the hepatic artery will affect the local lymphatic dynamics as well, and which will lead to further lymphostasis. Here we can see how the liver lymphatics interact with other epigastric area lymphatics. I've highlighted here the celiac lymph nodes, celiac axis lymph nodes, and here the cisterna chyli and the hepatic lymph nodes. So you can see how they're all connected together. This image, we can see how the stomach lymphatics also interact with the lymphatics supporting the liver. And of course, most of the lymphatics in the epigastric area coalesce into the cisterna chyli and then enter into the thoracic duct. Superficial hepatic associated lymphatic vessels form most of the posterior hepatic wall, known as the caudate lobe. The posterior surface of the right lobe contains lymphatic vessels that accompany the inferior vena cava. The coronary and triangular ligaments of the liver also contain lymphatic vessels that drain into the thoracic duct without interference. So that's a direct connection bypassing the cisterna chyli. So these ligaments have support that drains directly to the duct, which travels up through the mediastinum. There can also be a few lymphatic vessels that drain from the posterior surface of the left lobe of the liver through the esophageal opening towards the paracardiac nodes. So another image here, familiar one, just highlighting the fact that the lymph from and around the liver, because again we have the diaphragm here, but there technically is no liver here. But you can see the interactions of the movement of lymph. So a great deal, most of the lymph below the diaphragm, it will come down and then connect with the cisterna chyli and all the various lymphs of the epigastric area. But a great deal of them head back up and then connect deeply to the thoracic duct, as well as connecting the nodes that are connecting with esophageal lymphatics and in particular the lower esophageal sphincter of the stomach. Note how the lymphatics follow along with the arterial system emanating from the celiac plexus. So we have the celiac plexus aorta coming down here, and then the splenic artery, hepatic artery. So you could see how the lymph nodes are intimately connected in and around the celiac axis. The hepatic lymph nodes provide almost all the drainage for the liver, gallbladder, and bile ducts. They also support drainage from parts of the pancreas, stomach, and duodenum prior to sending lymph towards the celiac nodes and eventually to the thoracic duct. Lymph leaving the celiac nodes into the thoracic duct will be subject to the pressure gradients within the tissues surrounding the area. This can produce enough tissue resistance to limit the return of lymph back to the thoracic duct and eventually can end in abdominal, pelvic, as well as bilateral or unilateral lower extremity edema. So we start looking at, again, I've talked about perceived weight gain or people feeling bloated or swollen or holding water. And this is not a lymphedema diagnosis. It's just an observation of edema. And then it's important to consider the implications of the liver and the pressure around the liver as well as the epigastric area. The peripheral nodes, afferent vessels, come directly from inside the liver. The central group receives lymph from the peripheral nodes as well as the gastroepiploic, juxtapyloric, and pancreaticoduodenal lymph nodes. The efferent collectors of the group of central nodes are linked to nearby gastroceliac and superior pancreatic lymph nodes. We want to keep in mind that afferent means coming towards, and efferent means moving away from. Back to this image, it really exemplifies the liver acting as a hub for the intrinsic and extrinsic lymphatic system. We can see the multidirectional nature of lymph flow as it moves towards the cisterna chyli, towards the diaphragm and esophageal opening, and deep to the mediastinal lymph nodes, as well as to the thoracic duct. I've highlighted a few here: the mediastinal lymph nodes, pulmonary root lymph nodes, the thoracic duct itself, lumbar lymph nodes, and the celiacs. You can see how everything is really interconnected and giving you this idea of this deeper lymphatic system. In addition to the nodes and being connected to each other, we have to keep in mind that if the diaphragm and liver are creating too much pressure or tension in the area, then this lymphatic flow changes and it's more difficult for the flow to come back against the rate of resistance. The posterior mediastinal nodes collect hepatic lymph in a more direct manner than that of the internal mammary node due to the combined deep and superficial pathways. The hepatic drainage moving to the thoracic duct is less direct due to the required passage of lymph through various regional nodes prior to entering the duct. The convex surface of the liver is also supported by drainage via the bronchomediastinal trunk, and most of it terminates in the right side subclavian vein. So this is important when looking at examples of right shoulder pain, aching, even frozen shoulder. There are direct links to the lymph coming from the convex surface of the liver. And if there is congestion in and around the left shoulder, or pressure around the left subclavian vein, then this can lead to the chemoreceptors being triggered. Very small amounts of lymph from the convex surface of the liver terminates in the left subclavian vein. The left subclavian vein collects much of the lymph collected from the anterior portion of the liver, while the right subclavian vein receives lymph from the convex and posterior surface of the liver. That's coming from Millard. Here we can see the direction of lymph nodes as they approach the venous angle. So it's this same image. Here are the venous angles, and again the lymph. Thoracic duct is coming up through the center, but the lymph is being deposited into the venous angles by several different nodes, not just coming up through the primary branch of thoracic duct. And again, if you consider how much lymph the body produces every day, it's difficult to imagine that all of it is coming back and then being pushed through this collection of lymph vessels and nodes and then being deposited in the venous angles. I think, again, a lot of the lymph is being processed individually in the lymph nodes, as they do have venous and blood supply. So the lymph is moving along, but I think it's entering back into the blood supply all over the body, not just coming back here directly in the venous angles. I think it's coming through the venous system as it's interconnecting through the body. The liver produces about 1 liter of lymphatic fluid each day from the protein-rich fluid of the perisinusoidal space, otherwise known as Desae's space. Also important when we're looking at the liver as a hub for the lymphatic system, not just the connection of nodes, but also the fact that it's responsible for such a high degree of lymphatic fluid. From the Dysfunction spaces, the lymph then flows along the sinusoids and the efferent inlet venules toward the surface of the lobuli. The Dysfunction spaces are bordered on one side by the intrahepatic blood capillary sinusoids of the portal vein, and on the other side by the hepatic cellular plates. The Dysfunction spaces act as pre-lymphatic channels inside the liver. These channels travel to the initial lymphatic vessels situated in Moll's periportal spaces. Pre-lymphatic channels also occur in the spinal cord and in the brain, which I talked a little bit about in the cranial and cervical lymphovascular terrain. It is the role of the blood capillaries to act as the source of interstitial fluid flow into the pre-lymphatic channels. Understanding the role of the liver in the production of lymphatic fluid changes the consideration of addressing, fully any osteopathic lesions of the liver in all capacities. It's difficult to deny the fact that the liver is indeed a primary lymphatic organ, in that the production and movement of lymph fluid is so dependent on it. This image just lets us know we've got the hepatocytes represented up here. We've got spaces of Dysfunction. The spaces of Moll, the sinusoids, all of this interacting to work with the lymphatics. And the hepatic vein and the hepatic artery should be actually reverse color. Here they have it in red. For hepatic vein it should be blue, and obviously artery should be in red. From the surface of the lobuli, the lymph arrives at the spaces of Moll through the sieve-like basal membrane of the lobular surface. The space of Moll is a narrow fissure in between the periportal connective tissue and the basal membrane of the lobule. From the space of Moll, the lymph travels to the lymph capillaries. The liver has intrahepatic lymph capillaries that are in the interlobular connective tissues inside the periportal space. The lymphatic structures inside the periportal space also receive lymph from a lobule of the portal vein. The precollectors follow along with the branches of the portal vein and the hepatic artery to one side and the hepatic vein on the opposite side. The network of superficial lymphatics consists of subserous and intracapsular vessels, which form a unified plexus between the two. This allows for the superficial and deep lymphatic systems to communicate on a capillary level and via the lymphatic collectors. The superficial lymph collectors situated on the posterior surface of the liver drain into the posterior mediastinal and inferior phrenic lymph nodes. The collectors located on the convex surface of the liver drain into the right lumbar, pre- and lateral pericardiac lymph nodes and to the nodes of the hilus of the liver. These are the same, the convex surfaces, this lymph is also moving up towards the right venous angle. The vessels of the caudate and posterior part of the right lobe lead to the right lumbar lymph nodes. The right lobe of the liver has collectors on the posterior surface that send lymph along the falciform and coronary ligaments before passing through the diaphragm near the foramen of the vena cava. They go on to terminate in the juxtaphrenic nodes and eventually the posterior mediastinal nodes. There are also nodes that descend via the triangular ligament as they accompany the inferior phrenic artery before passing through to the inferior phrenic nodes. From here, they terminate in the celiac nodes, superior mesenteric, and lateral aortic nodes. And of course, the presence of lymphatic vessels inside the ligaments lends itself to osteopathic techniques, direct techniques such as pumping recoils or 50-50 fascial releases. Again, we want to remind ourselves that the hub-like action of the liver lymphatic sends lymph in multiple directions, as well as lymph production and lymph serving the liver itself to keep the liver cleaning as it's cleaning blood. So going to the posterior vessels of the convex surface a little more. The posterior vessels of the convex surface drain into the right lumbar lymph node situated next to the inferior vena cava. Some of this is just repeated. There are a few of the middle collectors that drain via the sternocostal triangle to the ipsilateral precardiac nodes. Further drainage occurs through the diaphragm along the attachment of the pericardium, ending at the pericardiac and lateral pericardic lymph nodes. So this is again lymph moving up above the liver, past the diaphragm, towards the pericardium. Posterior collectors enter the left triangular ligament to descend along the esophagus to the gastroceliac lymph nodes. A second group of posterior collectors accompany the phrenic nerve to pass through the inferior to the inferior diaphragmatic nodes. Drainage of lymph from the liver occurs at multiple depths of tissues and travels in all directions towards surrounding nodal chains. The lymphokinesis is multidirectional and complex. By design, there is no other organ in the body which has such a comprehensive escape plan for lymphokinesis and detoxification. Like a sponge, the liver attracts and expels in all directions relative to its mass, surfaces, and borders. Here we can see the aorta and the vena cava with its associated deep lymphatic structures. And what we want to pay attention to here is the entrance to the thoracic duct, which is positioned right in between both of them. And you can see how the lymph nodes are connecting to each other, moving in the general direction of the thoracic duct. Just an image showing the triangular and coronary ligaments, and reminding that we do have lymphatic structures that are passing through the inside of these ligaments. My assumption is that the structures are coming down, and since it's been noted that the lymph is coming from from above, it's most likely leaving the round ligament back down towards joining the lymph nodes of the cisterna chyli, which would be, somewhere central in the epigastric area. Although the entrance of the thoracic duct is in the epigastric region, the entire duct receives lymph at various portions as the lymph travels up towards the venous angles. This is providing the ideal pressure gradients persist to allow movement of lymph from superficial to deep. So again, there is an aspect of lymph flow that is moving up the thoracic duct, but there's also lymph that is moving from superficial to deep from all the various collectors in and around the lungs, the pericardium, the heart itself, the esophagus. Many of these lymph nodes are connecting with the thoracic duct deeper inside the body. Some of them are going to be moving superficially towards the venous angles. Eventually, as the thoracic duct comes up, it's connecting with the venous angles. But it is interesting that it serves as a central conduit for a lot of the deeper lymph that's moving up through the body. The deep vessels of the liver have two drainage pathways. The descending collectors follow along the branches of the portal vein, the hepatic artery, and the greater bile ducts. So the descending collectors will be moving against the direction of blood from the portal vein and the hepatic artery as they're moving down towards the cisterna chyli, and they will be following, however, along with the bile ducts. So there's less resistance coming from the bile ducts. There are also efferent vessels that exit the liver via the hepatic portal to terminate in the chains of the hepatic and gastroceliac lymph nodes. The ascending collectors follow along the hepatic veins and inferior vena cava through the foramen of the vena cava, ending in the right juxtaphrenic lymph nodes. The hepatic lymph nodes provide almost all the drainage for the liver, gallbladder, and bile ducts. They also support drainage from parts of the pancreas, stomach, and duodenum prior to sending lymph towards the celiac nodes and eventually to the thoracic duct. Again, come back to this image just to remind us of the multidirectional aspect of lymph moving away from the liver. And its interconnections with the lymph of the epigastric area, which we'll be covering in the next presentation. We'll go into epigastric, stomach, and small intestine. Just to summarize, the liver is the principal organ of the human body, supporting metabolism, detoxification, immunity, and digestion. The liver acts as a functional and physiological hub for the entire lymphatic network. The liver qualifies as a type of metabolic sponge whose shape, position, tone, density, and level of available functionality is critical in managing pressure gradient imbalances, lymphokinesis, and homeostasis. The functional relationship of the liver to the diaphragm, stomach, and spleen can be disturbed due to tensegrity imbalances and/or adhesions of connective tissues between structures. And many chronic health issues are rooted in the altered size or shape of the liver, leading to lack of adaptability and disturbed homeostasis. Going into the gallbladder lymphatics, the regional lymph nodes of the gallbladder and liver are interconnected with the nodes of surrounding organs, and the hepatic lymph nodes consist of a central and peripheral group. The central group typically has 1 to 4 nodes that lie near the horizontal part of the common hepatic artery. The peripheral group has 2 to 3 nodes that lie inside the hepatoduodenal ligament, near the ascending part of the hepatic artery on the left edge of the portal vein. Again, another ligament that is containing lymphatic structures. The initial lymph vessels of the gallbladder form a muscular and mucosal plexus. Lymph passes from the muscular plexus towards the subserous plexus, which contains 2 to 4 times the lymph vessels of the mucosal plexus. The efferent vessels begin in the subserous plexus. This image here of the blood supply to the liver, we can see the gallbladder here. We can also have highlighted here the intersection of the hepatic artery, common bile duct, and the portal vein. A little bit of a cross section, so you can see how they're all interacting. And of course, these are all wrapped in a tendinous sheath referred to as portal triad. It also will contain a branch of vagus nerve coming through it. Here we have another good image of the liver with the gallbladder and its various ducts. And important to just consider how vulnerable the gallbladder is to the liver itself. The pressure, any excess pressure or density in the liver will certainly affect the function of the gallbladder. When we talk about liver dysfunction and portal hypertension in particular, we want to keep in mind that anything obstructing blood flow through the portal vein back to the liver can lead to portal hypertension. According to the Cedars-Sinai Institute, some symptoms include enlarged liver and spleen, hemorrhoids, enlarged veins, fluid buildup in the belly, kidney malfunction, low platelets, fluid in the lungs, and internal bleeding. Of course, portal hypertension can be rooted in mechanical and pressure gradient insufficiencies or imbalances. Osteopathically speaking, we may find several issues classified as osteopathic lesions that would participate in the dysfunction of portal hypertension. Some causes of portal hypertension, according to Mount Sinai: clotting of the veins in the liver, clotting of the portal vein itself, and scarring of the liver and cirrhosis. Given the associated symptoms, it's easy to see how chronic respiratory infections could be the result of localized fluid stasis due to lower extremity portal hypertension. In fact, the increased pressure gradients appear to be systemic, which is why we see symptoms occurring in the rectum as hemorrhoids as well as in the lungs. Once the liver becomes overwhelmed within the dynamic of portal hypertension, the entire homeostatic mechanism is under threat. I think it's also worth considering that liver dysfunction can lead to portal hypertension, creating a vicious cycle of stasis and increased pressure and that increases allostatic load. So if the liver is not available to receive the blood from the portal vein, then the symptoms are all going to look the same. The key is to try and liberate the mechanism, making the liver available and then creating the space, removing tension so that the blood from the small intestine can flow back effectively to the liver to be processed. When there's an obstruction of the hepatic venous system, the thoracic duct lymphatic drainage increases. Blood plasma will be converted into lymph at an abnormally high rate when there is evidence of systemic congestion or dysfunction within the portal venous circulation. This can result in 3 to 4 times the blood volume in a 24-hour period being converted into lymph. The result is congestion that exceeds the flow capacity of the thoracic duct and venous junction, eventually leading to thoracic duct distension. Venous stasis can be a symptom of lymph blockage, but it is a blockage that leads to congestion and foreign growths. Indurated lymph nodes will limit the amount of lymph flow due to the inability to properly filter substances. Here we have an example of a homeostatic mechanism. As the lymphatic system adapts to venous hypertension, its reaction indurates the lymph nodes and contributes to venous hypertension. It's a vicious cycle and an example of allostatic load. And I think these types of cycles are the foundations of chronic issues related to inflammation and congestion. The implications of portal venous congestion can contribute to unilateral or bilateral lower extremity edema, pelvic edema, abdominal edema, as well as hemorrhoids, gout, bladder infections, constipation, lower back pain, and bloating. And again, we can appreciate the influence of portal hypertension on the thoracic duct as the increased lymph formation overburdens the cisterna chyli and also causes the expansion of the thoracic duct itself. Note that the inferior mesenteric vein and superior mesenteric vein terminate in the left and right lobe respectively. This is an important distinction as the left and right lobe have distinct functions, including phase 1 and phase 2 detoxification pathways. Talked about this already. Here we can appreciate the systemic implications of portal hypertension from the pelvic bowl to the cranium and the venous sinuses when we look at the valveless venous plexus through the body. In terms of a protocol, prior to addressing any venous stasis, it's important that the normal functioning of the liver be restored, or the clearing of lymph vessels and veins will be compromised. When the liver is sluggish and inactive, there may be an eventual stasis or lymph blockage that would be reflected in the immediate organ and tissues. The lesion will act as a blockage to proper lymph flow out of the pelvic region via the portal vein. In this case, it will be accompanied by puffiness in one or both ankles and knees. Now, this is coming from Millard, his observations 100 years ago. I think the reason why Frank Millard recommended liberating the liver before addressing venous stasis is due to its role as a hub of the lymphatic system. The hepatic circulatory theory and the extensive lymphatic participation of the liver reveal how the liver acts as the center of a circulatory fulcrum, connecting upper and lower fluidic and pressure gradient dynamics. When we migrate away from the center, or otherwise known as homeostasis, we inevitably suffer the cost of increased atostatic load and pathology. This image is meant to show what portal hypertension looks like inside the liver as you've got the expanded various veins and sinuses. Frozen shoulder information coming from the Mayo Clinic, known as adhesive capsulitis. The symptoms are left or right shoulder stiffness and pain. Start off slowly and gradually get worse and take between 1 to 3 years to resolve itself, as there is no current protocol for short-term success, according to the Mayo Clinic. Caused by the joint capsule thickening and tightening, and this limits the range of motion. Most common with women over the age of 40. The following diseases are often linked to adhesive capsulitis: diabetes, overactive thyroid, underactive thyroid, cardiovascular disease, and Parkinson's disease. The most common characteristic of women over 40 are hormonal imbalances, weight gain, systemic edema, chronic sleep issues, bloating, digestive issues, fatigue, depression, skin issues, reduced immune resiliency, and this does not include the natural stages of menopause overlaid on top. All of these symptoms have implications related to insufficient detoxification, dysregulated microbiome, and underperforming lymphatic support. Efficient drainage of the liver will contribute to alleviating detoxification side effects from extracellular tissues, as well as assist in reducing chronic inflammation, including right shoulder pain, frozen shoulder, chronic fatigue syndrome, and many upper extremity musculoskeletal pain complaints. That's coming from Bruno Schickli. Dr. Schickli's observations regarding a protocol for treating adhesive capsulitis makes complete sense when we reflect back on the anatomy of the lymphatics. Keep in mind that the right shoulder lymphatics are more connected to the liver lymphatics than the left shoulder, in particular the convex surface of the liver, posterior aspects of the liver. Often patients will have it resolve in one shoulder and then begin another cycle in the opposite shoulder. I would add that there's also likely some degree of functional portal hypertension contributing to the frozen shoulder scenario. I've treated several cases of frozen shoulder in both men and women and had a total reduction in symptoms without even treating the shoulder joint. Obviously, the results depend on what stage of frozen shoulder presents, but in all cases, there were other associated health imbalances, and the shoulder pain was just a symptom of a greater systemic problem. In fact, liberating systemic lymphatic flow not only resolved the frozen shoulder, it also reduced systemic edema, bloating, and digestive issues their sleep improved, their bowel movements improved, their skin improved, their energy improved, their resiliency improved, their mood improved, and as I believe the root of the vicious cycle of frozen shoulder is toxicity. Again, just the basic aspect of lymphatics. Doesn't cover the whole story. Does it allow us to really see how the deeper lymphatics work? But with the help of this image, we can reflect a little bit. Keep in mind how we have the vascular tree, arterial system coming down through the body, moving out, branching out through the body, starting at the heart there, then coming up through the subclavians into the carotids, into the cranium. So we know for a fact that the lymphatics are wrapped around all of these aspects of the vascular tree. We also know that the lymph is returning back against that flow, as is the venous system, the venous tree. Blood is returning back to the venous angles against the resistance of the arterial pressure. We also know that we have the diaphragm aspect and the liver itself, this region combining with the diaphragm. This is affecting pressure gradients in the mediastinal area and below the diaphragm in the abdominal pelvic area. These, when there's an imbalance between the upper and lower pressure gradients, we're going to have stagnation of lymph. When that lymph stagnates, there are aspects of the body where the lymph will collect. You will see it in the thighs, in particular the medial aspect of the thighs. It will feel on both sides puffy. In behind the knee, puffiness. Around the ankle and foot, puffiness. Pelvic or abdominal bloating. Axillary puffiness, including at the upper portion where the above the clavicle, and you'll see around the lymph nodes, around the throat, around the cheeks. You can see edema collecting. Now, if you add all of these up, it looks like weight gain, but that's not always the case. It can certainly be the case that the body is just holding on to excess fluid. Just finishing up with the frozen shoulder, given the number of local lymph nodes supporting the axilla area, it's easy to see how a regional or global lymphostatic dynamic can end with adhesive capsulitis. Just a good general manual therapy protocol for the lymphovascular terrain. Well, in particular liver, it involves differentiating the liver from its neighbors, restoring the intrinsic shape, also known as the morphological imprint of the liver. Restore ideal tissue toneness in the form of pressure gradients within the liver and surrounding the liver. Liberating circulation to the various liver segments. I find it helpful to perceive the liver as a type of metabolic sponge which has the capacity to alter its shape according to the demands placed on the various segments of the liver. This is in response to its various roles physiologically in the body, its ability to be easily insulted, and also one other factor is we want to ensure there's proper blood supply going to and from the liver. Moving on to the diaphragm. The diaphragm powers the thoracic pump as it sits beneath the lungs in the shape of an umbrella. During exhalation, the diaphragm ascends and tightens as it shrinks the lungs. During inhalation, it will descend and expand. This continuous movement occurs roughly 30,000 times a day. Adults typically only utilize 10% of the available range of the diaphragm when breathing, and this leads to overburdening of the heart. The result can be elevated blood pressure and many circulatory related problems. The diaphragm can be considered a second heart as it moves to its own rhythm, as well as influencing the function of the heart. Studies regarding the function of the diaphragm in emphysema patients confirmed by X-rays has shown that excursion of the diaphragm was severely limited in range of motion. The cause appeared to be a gradual atrophy due to lack of use. According to Di Giovanni, the diaphragm is a dome-shaped muscle with two lateral hemidiaphragms whose shape is influenced by the viscera. In addition to inspiration and expiration, the diaphragm is important in micronutrition, defecation, circulation of blood, lymphatic pumping, and speech. According to Sills, the respiratory diaphragm may also reflect the torsion pattern by tensing, leading to a host of secondary symptoms including shallow breath, tight chest, general inflexibility, and nerve sensitization. I have seen this as a common finding when working with infants and adults alike. Although the loss of ideal function of the respiratory diaphragm is an example of loss of adaptability and viability at any age, there are specific characteristics that are present in the aging population. Most of these patterns are attributed to primary sarcopenia with aging and secondary sarcopenia due to pathological influence. The elderly experience a decrease of 10 to 41% of transdiaphragmatic pressure and a decline of 30% in overall expiratory strength. This ultimately influences the speed of contraction and the decline in muscle coordination, leading to an increase in falls. In addition, other symptoms include urinary incontinence, dizziness, depression, anxiety, and obstructive sleep apnea syndrome. From a postural perspective, we see the advent of dorsal kyphosis, decreased elasticity of pulmonary parenchyma, stiffness of the joints in the chest, and hyperinflation. The hyperinflation is a result of an increase in residual volume and functional residual capacity. The thickening of the diaphragm can also lead to vagal nerve degeneration as the vagal nerve innervates the portion of the esophageal breath and the intercostal nerves innervate the paracostal and intercostal muscles. That's coming from Bordoni, 2020. The position of the diaphragm in the individual is variable and is relative to the shape and size of the body. The anterior position of the right cupula is equal to the fourth costal cartilage, or at the level of the right nipple. The left cupula is located one rib lower than the right during forced expiration. Both cupulas are able to descend approximately 10 centimeters inferiorly towards the tip of the sixth rib. The diaphragm muscle is a continuous sheath that can be divided into three parts. The sternal portion, although not always present, arises as a pair of fleshy strips situated on the posterior part of the xiphoid. The costal portion arises at the lower six costal cartilages on the internal surface, including the accompanying ribs, prior to weaving into the sheath of the transverse abdominis muscle. The last portion being the lumbar portion of the diaphragm, beginning at the medial and lateral arcuate ligaments as paired aponeurotic arches. Additionally, there are two pillar-like attachments at the lumbar vertebrae known as the crura. All of the circumferential portions of the diaphragm converge fibers to create the central tendon of the diaphragm. Medial fibers of the right crus wrap around the descending esophagus as it travels through the aperture. The central tendon is positioned anteriorly in the thoracic, resulting in the posterior fibers being of greater length. The central diaphragm lies adjacent to the inferior portion of the pericardium, and both provide a link to each other via blended fibers and ligaments. Taking into consideration the attachments to the diaphragm, the tendinous and muscular aspects to the diaphragm, and its 30,000 contractions per day, it's easy for me to see it as possibly the strongest muscle in the body. Consider the strength required to try and stop someone from sneezing. How many people would you have to pile on them in order for that to be successful? The left side of the cupula shapes to the left lobe of the liver, the left kidney and suprarenal gland, spleen, and the fundus of the stomach. The right side articulates over top the convex surface of the right lobe of the liver, as well as the right kidney and suprarenal gland. The diaphragm has an opening for the esophagus, aorta, and inferior vena cava. The lowest and most posterior of the openings is the aortic aperture, and it can be found slightly left of midline at the lower level of the 12th thoracic disc vertebrae. The opening is a fibrous ring made from parts of the medial crura as they pass behind the aorta. The aortic aperture also carries azygos vein, thoracic duct, and lymphatic trunks from the lower posterior thoracic wall. At the level of the 10th thoracic vertebrae sits the esophageal aperture in front, above, and slightly left of the aortic opening. Through it passes the esophagus, gastric nerves, and lymphatic vessels. The opening is elliptical and is bound to the medial portion of the right crus. The vena cava aperture is located at the junction of the central tendon and the right leaf of the diaphragm at the level of the disc between the 8th and 9th thoracic vertebrae. It is the highest of the three openings and is crossed over by the inferior vena cava and certain branches of the phrenic nerve. There are also two additional, much smaller apertures designed to permit the passage for the greater and lesser splanchnic nerves. The passage of the ganglionated sympathetic trunks pass into the abdominal cavity deep to the medial arcuate ligaments and behind the diaphragm. Auxiliary inspiratory muscles include the scalene, sternocleidomastoid, the serratus posterior superior, the pectoralis, the lat dorsi, the inferior fibers of the serratus anterior, and the fibers of the iliocostalis muscles. Expiration occurs at a natural recoil of the diaphragm and the energy stored in the costal cartilage. This includes the internal intercostals and the sternocostalis. Expiratory accessory muscles include the rectus abdominis, internal and external oblique, serratus posterior inferior, transverse abdominis, transverse thoracic, pyramidalis, subcostals, quadratus lumborum, and iliocostalis. It's worth considering that a dysfunctional diaphragm can lead to overburdened accessory breathing muscles, such as the scalenes, as they connect to the apical pleural dome, or it can also affect something like the quadratus lumborum muscles or psoas muscle, contributing to shortening of the psoas. The phrenic nerve branches from the ventral rami of the 3rd, 4th, and 5th cervical nerves and innervates the diaphragm. This supports the sensory input to the diaphragm along with contributions from the intercostals. The 11 pairs of costal nerves and their dorsal and ventral rami supply the vertebral portions of the diaphragm. The intercostals are connected to the chain of sympathetic nerves via the communicating rami located at the interior heads of the ribs. So we can begin to see how any dysfunction in the cervical spine or the ribs themselves will have an impact on the function of the diaphragm. The diaphragm has afferent vagal fibers that have a large and small diameter, as well as myelinated and non-myelinated characteristics. Large fibers are activated during the contraction phase of inspiration of the diaphragm, and the small fibers activate in both inspiratory and exhalatory phases. The phrenic afferents reach the cerebellum, the limbic area, including the thalamus, amygdala, prefrontal cortex, periaqueductal gray area, hypothalamus pituitary, and the somatosensory cortex via spinobulbar pathways and spinothalamic pathways. Furthermore, both sides of the cortex, where the position of the diaphragm muscle is represented, can communicate via the corpus callosum cortical pathways. That's according to Bordoni. So it's easy to see how stress could lead to stress breathing, unconscious stress breathing, that will have a profound impact on the function and even position of the diaphragm and its tone. An optimally functioning diaphragm can stimulate the baroreceptors located in the aortic arch and carotid glomus. This occurs during deep inhalation, and the baroreceptors will travel to the solitary tract. The nucleus of the solitary tract will in turn respond by sending efferent inhibitory signals to the medullary ventrolateral rostral area, which will improve coordination and muscle strength of the diaphragm. In the elderly, it is also observed that they have altered baroreceptor afferents, as well as higher sympathetic system activity values. This altered baroreceptor function leads to vestibular dysfunction and consequent motor control dysfunction and dizziness. There are implications of life expectancy with a cycle of fatigue and motor respiratory incoordination, resulting in increased morbidity. When the diaphragm becomes fatigued, there's an increased production of inflammatory substances, as well as a reduction in blood volume to the muscle. As the diaphragm loses its viability, there is a gradual loss of the vagal brake mechanism. That's coming from Bordoni. In light of available data, we can hypothesize a negative influence of the adaptation of the diaphragm muscle to the decline of certain functions, such as the motor incoordination of the limbs and a higher percentage of falls, as well as cognitive decline. The percentage of low back pain feedback in healthy older people is high, and one of the causes is a dysfunction of the diaphragm muscle, which does not adequately support the movement of the lumbar vertebrae. Inspiratory muscle weakness in patients with chronic obstructive pulmonary disease is of major clinical relevance. Maximum inspiratory pressure generation is an independent determinant of survival in severe COPD. Traditionally, inspiratory muscle weakness has been ascribed to hyperinflation-induced diaphragm shortening. However, more recently, invasive evaluation of diaphragmatic contractile function, structure, and biochemistry demonstrates that cellular and molecular alteration occurs, of which several can be considered of a pathological nature. The implications appear to be that the muscle of the diaphragm has a capacity to degenerate, as do all other tissues in the body under pathological influences. I think it's possible that one could consider the diaphragm as the strongest muscle in the body, given its ability to hold on to tension. The range of motion may not be as broad as other muscles, such as the quadratus femoris, but it is a circular-oriented muscle that clearly provides a force that is for the most part hidden from us. Hidden in the sense that we take roughly 30,000 breaths a day as an unconscious action. I'm not sure of any other muscle that receives as much training as the diaphragm. Therefore, it's not surprising to learn that its dysfunction has an impact on morbidity. The intrinsic diaphragm alterations are observed to be degenerative in nature. These are due to biochemical and even morphological characteristics of the diaphragm, contributing to the pathophysiological framework. One of the changes occurs in the shift to more oxidative fibers within the muscles from fast twitch to slow twitch fibers as an adaptation to dysfunction. Once the transformation of fibers, including the loss of myosin, occurs, there is a reduction in the available force generation. The result is a loss of elasticity, including passive tension. What we are left with is diaphragm atrophy. Clearly, there's a role to play for the surrounding lymphatic structures traveling to and from, as well as through the diaphragm. The combination of systemic inflammation combined with a more sedentary lifestyle can easily lead to a loss of diaphragm function and intrinsic fiber composition. Meaning, if there is congestion in and around the diaphragm because it's not functioning properly, that will lead to inflammation and tissue degeneration. The topic of inflammation and oxidative stress in or around the diaphragm promoting atrophy has led to a systemic hypothesis theory. This involves the circulating cytokines that are observed during rest, contributing to striated muscle injury. Other potential causes of increased diaphragm atrophy are nutritional depletion and increased free radicals, as they also contribute to systemic inflammation. Getting into the lymphatics of the diaphragm, lymphatic drainage of the deeper tissues of the thoracic diaphragm wall occur via the diaphragmatic nodes, closely following along all arterial branches. There are a small group of lymphatic nodes underneath the xiphoid process. Intercostal nodes will eventually drain into the abdominal confluence of lymphatic trunks, which is the entrance of the thoracic duct. There are also lymph nodes at the point near where the phrenic nerve enters the diaphragm. Afferent lymphatic vessels on the right side of the diaphragm also drain the convex surface of the liver. There's that connection again, and that of course connects to right shoulder. There are also nodes at the posterior aspect of the crura. There are also lymphatics that primarily drain the muscles that attach to the ribs. Lymphatic vessels of the deep diaphragm, lymphatic plexus, anastomose with the nodes of the abdominal plexus. There is also continuity between the costal and mediastinal pleura with the thoracic plexus. The junction of the cartilage and the seventh rib is the location of the anterior diaphragmatic nodes. Deeper nodes exist on the esophagus posterior to the seventh rib at the sternum, and deeper still there are nodes around the aorta as it exits the thorax. The diaphragm nodes are connecting to these deeper lymphatic system. The abdominal plexus anastomoses with the hepatic lymphatics as well, as a reminder. The diaphragm has two networks of initial lymph vessels. There's a network of diaphragmatic pleura located on the thoracic side for the diaphragm. The subperitoneal lymph vessels are located on the abdominal surface. The diaphragmatic pleura and the muscle of the diaphragm are drained by the subperitoneal pleural lymphatic plexus. The anterior and posterior drainage territories of the diaphragmatic pleura communicate together at the posterior margin of the central tendon of the diaphragm. The anterior portion of the diaphragm that fuses with the pericardium contains no lymph vessels. The diaphragmatic pleura is divided into anterior and posterior sections, as this corresponds with the direction of lymphatic drainage. There are a few lymphatic vessels of the posterior territory that perforate the diaphragm to drain into the uppermost para-aortic nodes. The nodes next to the abdominal portion of the esophagus, the pancreas, and the lesser curvature of the stomach. So just one last image in closing. I'd like to add that the traditional map of lymphokinesis indicates that the lymph travels back to the venous angles to be deposited into the blood supply. This may be anatomically correct, but it's more likely that lymph gets processed locally by lymph nodes all over the body. That's why I mentioned this before. They're supported by veins and arteries. I suppose the lymphatics have to end somewhere. However, I don't think it's as simple as stating that the terminus is at the venous angles. One thing is certain is that the negative pressure of the mediastinum will draw lymph back towards the venous angles with the support of the diaphragmatic pump. Just one last image here looking at the lymph vessels that are located above the diaphragm and around the pericardium and around the ribs. So again, there's some of these are going back up towards the independently connecting to the venous angles, and some will be connecting deeper to the thoracic duct. So this completes my presentation. Here I'll supply a few pages for the bibliography so you can have a look at the various authors. And the next presentation will be on the epigastric area, which will include the stomach. And thank you for your support. I hope you're finding this helpful, and I'll see you in the next presentation.